Hi, everyone. Our first speaker is Dr. Samantha Gonzalez. She completed her undergraduate studies at the University of Miami and went on to attend Ponce School of Medicine, where she attained her medical degree. She rejoined the University of Miami to complete a combined Med-Peds residency at the University of Miami and Jackson Memorial Hospital, where she later served as ambulatory chief resident for the internal medicine residency program. With an interest in both primary care and medical education, she joined Holy Cross Hospital in Fort Lauderdale, where she served as Associate Program Director for their University of Miami Internal Medicine Residency Program, while practicing primary care and working closely with the LGBTQ+ community in her Wilton Manors practice. She rejoined the university in 2022 as primary care physician at UHealth Fisher Island and currently serves as Ambulatory Associate Program Director for the Internal Medicine Residency Program. In addition to her roles in primary care and medical education, she is a senior advisor for child health for the Global Institute and is a volunteer medical director for the student-run DOCS Rapid Access Wellness Clinic, which focuses on providing free gender-affirming hormonal care in the greater Miami-Dade community. Please welcome Dr. Gonzalez.
Hey, hear me? Okay, excellent. So good afternoon. I'm happy to be representing the Division of Med-Peds as
Closer to you.
closer. Excellent. As I take you through a case of transmasculine gender affirming care, I have no disclosures. In a perhaps ambitious 25-minute talk, I hope to cover some key points related to known barriers for transgender and gender diverse patients, review the general approach to gender affirming care, and review some transmasculine specific medical hormonal management and surveillance, non-medical strategies for gender affirmation, and some cancer screening recommendations. I'd like to convince you through this talk that you probably already know a lot of what you need to know, and I want to highlight some resources to help you along the way as you take care of these patients. All right, so we have to navigate a case of a 34-year-old male patient with known ADHD and depression who presents for an initial with our clinic. For gender affirming care, patient was assigned female at birth and uses he, him pronouns. I think to sort of set the stage, we need to know what are some of the things that affect the transgender population. So before we even get to our patient, less than 1% of US adults are transgender, which amounts to approximately 1.6 million people who identify with a different gender than the one assigned to them at birth. Gender diverse people experience unique, well-described social challenges, including discrimination, rejection, and the threat of physical and sexual violence, which can lead to this toxic social environment that may have profound impact on both mental and physical health. They also, unfortunately, face increased rates of fatal violence that we know disproportionately affect Black transgender women. In 2022, the National Center for Transgender Equality conducted really one of the largest transgender surveys, gathering information from about 92,000 people. And the respondents were from all 50 states. From this, we've learned that gender diverse people live across the US, with a larger proportion living in the South where we reside. And we also learned that 40% of those respondents had thought about moving to another state because they experienced specifically discrimination or unequal treatment where they were living. 10% at the time of the survey actually had moved. Gender diverse people we know have an increased risk of being unhoused, which increases the risk of them avoiding medical care altogether compared with those that are housed. And we sadly, but perhaps unsurprisingly, are among the top 10 states that respondents reported leaving. So it's even more important for us. Florida is unfortunately one of the states with the highest rates of fatal violence to trans people in the US. So what do we know about how trans people and gender diverse people access healthcare? 24% of respondents didn't see a doctor when they needed to in the last 12 months due to specifically fear of mistreatment. And about half report having at least one negative experience, and that included anything from refusal of care, misgendering, or physical or verbal abuse from a provider, which I thought was pretty surprising. 2018, we have an ACOG study, which is a survey of providers. 3/4 of clinicians said they had never encountered a transgender person, arguably that they know of. And only 2/3 felt that they had received enough education to provide medical care to transgender patients. To date, there's still no licensing board that requires education on trans patients, and trans medical care for certification. But some good news is that about 2/3 of medical schools do report including some transgender training. Some more good news, we have guidelines. So we have several guidelines, Endocrine Society guidelines, we have UCSF, Center for Trans Excellence guidelines, but the most up-to-date are the World Professional Association for Transgender Health, or WPATH. And these guidelines are from 2022. They're the SOC 8, Standards of Care for the Health of Transgender and Gender Diverse People. And this provides an evidence-based comprehensive guideline on all aspects of transgender healthcare, including hormonal therapy, reproductive and sexual health, surgery, mental health, and social support for these communities. Additional components include knowledge of speech therapy and voice training, as well as appropriate cancer screening. And all of this is really done in the lens of risk reduction and identification of modifiable risk factors. So what are those? We know gender diverse individuals face minority stress. That's a term which refers to chronic stress experienced by members of marginalized groups due to their stigmatized social status, which has physical and mental health effects. Evidence suggests transgender patients have a higher rate of undiagnosed and untreated cardiovascular disease, and data using self-health reporting showed both trans men and trans women have a higher prevalence of MI, stroke, and any CVD compared with their cis counterparts. Of course, we know some other sort of associated diagnoses that are seen in higher rates in trans patients. The mental health disparities include increased rates of depression, anxiety, PTSD, and suicidality, which unfortunately is not just limited to suicidal ideation. Survey results suggest that nearly 40% of trans people have actually attempted suicide at least once, and those are just the ones that live to tell us about it. All this to say, by being well informed, we can build trust and improve patient outcomes and address the specific needs of transgender patients with greater empathy. So back to our patient. So our patient, 34, trans man, describes noting gender incongruence first in the teenage years, but just recently decided to start hormonal transition about 6 months ago. He's been using weekly intramuscular testosterone injections, but he doesn't really know the dose because he's procured this from a friend and he ran out a few weeks ago. He's not previously been under the care of a medical provider for this care, even though he does say he has a primary care doctor, he just wasn't comfortable talking to them about their transition. And he started using an over-the-counter medication called estradiol we had to look up, which he heard could speed things along. He does follow his psychiatry for ADHD and depression, which is well controlled on medication. When we ask about goals for therapy, the patient wants to live in society as a man and specifically wants to appear more masculine externally, have increased strength, more facial hair, and desires top surgery eventually. So in an ideal world, before any patient starts treatment, there's a couple checklist items that we should be going through with them. When we think about the social transition, it refers to non-medical steps that trans individuals might take to live in alignment with their gender identity that's not related to medication. And note that not all patients are able to safely socially transition. For our patient, he lives in a home in Miami with his spouse, long-term female partner. They have 2 kids, an 8-year-old that was birthed by his partner and a 2-year-old birthed by him that were conceived via sperm donor. He works as a private CNA for a patient with dementia, and he reports using gender-neutral nicknames since teen years, but he just most recently adopted he, him pronouns. He self-reports that he happily lived as a butch lesbian and enjoyed being confused for a man multiple times in his adult life, and so this is not a great change for him. We should be counseling patients on the expected physiologic changes of hormone therapy, so what can and can't be achieved with hormone therapy. And at this point, we should also identify medical problems which may be exacerbated by presence or newly absence of hormones. For our patient, notably, he has a history of gestational hypertension with that pregnancy, ADHD on stimulant medication, multiple family members with hypertension and hyperlipidemia, and he's on Adderall and estradiol. We have to talk about reproductive health in all cases before starting hormonal therapy. Testosterone, we know, can suppress ovulation and might lead to reduced fertility, but the effects are not necessarily permanent. At any rate, we need to talk about it. It's generally oocyte cryopreservation or embryo cryopreservation. Luckily, our patient already went through this process in an effort to become pregnant with his second child. And the couple is pretty satisfied with their family planning and have no plans for further children. We should be able to discuss or at least be knowledgeable about the kinds of surgeries transmasculine patients may seek. Really, when we think about surgery, only about 50% of medically treated trans people also seek transgender-specific surgeries, and they're usually only sought after hormone therapy for at least a year or living in the affirmed gender for at least a year. Mastectomy is the most commonly sought procedure for transmasculine patients and is widely available because there are a lot of people that can do it. So we are, back to our patient review systems. He's, mentions, of course, last minute, there's a rash on his chest. It's been there for about a year. He does report wearing a chest binder for more than 12 hours a day for at least the last year. He screened positive on an intimate partner violence screening questionnaire, which we need to address. And on his physical exam, it's notable for elevated blood pressure, elevated BMI. Binder was in place, and the rash is consistent with a fungal rash we usually see in binder use with transmasculine patients. So what are the considerations? Do we have a newly transitioning patient? He's getting unsupervised medical hormonal treatment. He's got comorbid depression, ADHD, on stimulant therapy, SSRIs. We detect elevated BMI, elevated blood pressure, positive intimate partner violence screen, and he's behind potentially on cervical cancer screening. He does report emotional dysregulation after starting therapy and possible binding associated rash. So seems like a lot, but I guess I'd challenge you, is it really? It's not uncommon in primary care to come across patients who take medications that their neighbor or their auntie gave them for a symptom that they have. It's not uncommon for us to take care of patients who have multiple cardiovascular risk factors and then need to be on a medication that we have to monitor. And we always in primary care get hit with that rash as they're walking out the door that they forgot they've had for a whole year. So this is the most primary care thing ever, right? So I'd like to convince you this is not that daunting. Some things may feel a little bit less familiar, but most people know probably most of what they need to know to navigate this, and I'll try to convince you of that. But remember that you always have, there's always space for pulling in other specialists as you need to if you encounter areas of uncertainty. A common question I get from peers or from my past residents, can I even do this? Like, is this within my scope to determine if a patient is a candidate for hormone therapy? And in most cases, the answer is yes. Guidelines no longer require 2 providers to agree, but your patient has to meet some criteria, which include a persistent, well-documented gender dysphoria, an ICD-10 code, or gender incongruence, an ICD-11 code. And I mention those because they may be required for reimbursement depending on where you live. Patient obviously has to be of age of majority and have capacity. And if significant mental health concerns are present, they must be reasonably well controlled. So the presence of mental health comorbidities does not preclude a patient from being a candidate for therapy. It is important that we know the laws in our state and that we acknowledge that these may evolve. In Florida, there's specifically SB 254, which mostly focuses on banning gender-affirming care for minors. But regarding adult care, it limits who can prescribe hormone therapy, so just MDs and DOs in the state of Florida, and it adds a specific state-mandated informed consent requirement, I'll show you in a moment, using specific forms approved by the Florida Board of Medicine. These are the rules that were adapted that we know of for this. The only mandated penalties for physicians are related to banned treatments to minors and only include potential license suspension or revocation. So if you're really doing adult transgender hormonal care, right now it's legal to do that in Florida. The other rule that is worth knowing, in 2022, Medicaid said that their funds would not cover any gender-affirming treatments, and so that also affects our care. And this is a website you go to pull the specific consent form, scan it in the chart, and now we're ready to take care of our patient. When we're talking about hormonal therapy for transmasculine patients, it's really just T. Testosterone, we use it for other patients. Hormone level goals are to get them as close to cisgender male counterparts, right? So testosterone between 300 and 1,000, and estradiol generally below 50. There's nothing much else to it. It's all the same medications and the same things to look out for. Just like a brief look at aromatase inhibitors, since our patient went rogue and bought a medication called estrahalt we had to look up. It's marketed as a natural aromatase inhibitor. Right now, we have insufficient evidence to recommend aromatase inhibitors, and we are concerned about side effects, including bone density loss, joint pain, hot flashes, mood changes, fatigue, and headaches. So back to testosterone. I don't need to tell you about this. These are all the same medications, all the same starting doses that we generally use for testosterone for other indications in cisgender patients. I've added here some price tags since we know that Medicaid may not be paying for this. These are just pulled from GoodRx, from local pharmacies, what a 1-month script for these would cost, which may be a consideration for your patients. What might be different is the expected physiologic change you see in your patient. So the most important thing here is knowing the extent and timing of sex hormone induced changes may prevent potential harm for your patients, and expense of unnecessary treatment changes, dose increases, and premature surgical procedures. We have to counsel our patients that some of these things will take maximum effect several years after they start them, but we should know more or less what patients should expect and should be counseling them on it. Our patients noticed clitoral enlargement in the last 6 months, increased facial hair, and some weight gain, and some undesirable side effects, increased emotional dysregulation, including irritability, increased aggression, and he's denied becoming physically violent from this. What to look out for? The usual things: elevated blood pressure, usually at around 2 to 4 months after initiation of therapy. Our patients can have an altered lipid profile, and we're always going to be monitoring for erythrocytosis. So it's unsurprising that these are the labs that we get initially and throughout the care of the patients: just total T estradiol, CBC, BMP, and a lipid panel. I add STD testing because of the increased rate of STIs in this population, so always think about it. And the frequency: every 3 months for the first year, then every 6 months when you achieve hormone stability. These were our patient's labs at the time, the day that we saw him. Ultimately, he's been a couple weeks off of therapy. His T's subtherapeutic, his estradiol's a little bit high. We pulled prior baseline labs and showed that this is kind of a major increase from before. And so we did counsel the patient on the risk of erythrocytosis and the need for potential therapeutic phlebotomy in the course of his treatment. We can't forget our patient had a positive intimate partner violence screening questionnaire. They did cite emotional abuse only, specifically mutual screaming, verbal abuse, including insulting and cursing. Upon further discussion with the patient and the partner, tensions have been high. The patient's experiencing this emotional dysregulation at the start of hormonal therapy. They have 2 young kids. The spouse expresses a feeling of grief for the loss of who previously was. They had a decade of living as a lesbian couple in society. And so we absolutely recommended individual and family counseling throughout the adjustment period, which is pretty good, just standard practice. Factors that have a positive impact on mental health: family acceptance, supportive social and romantic relationships, things that sort of make sense. Gender affirming hormone therapy is also one of those things. So I just wanted to take a moment to consider some specific things that transmasculine patients use to affirm their gender that may not be medical. Chest binders may involve the use of tight-fitting sports bras, as you can see here, but they also can use shirts, ace bandages, or specific binders created for this. Sometimes people don't have access to this, and they may use inappropriate materials that can lead to risk of rib fractures and a restrictive breathing pattern in, of course, extreme cases. But prolonged binding may result in breast pain, skin irritation, and fungal infections, which is what we were seeing in our patient. Safe binding practices recommend limiting binding to no more than 8 to 10 hours per day. We know our patient has been using it for greater than 12 hours because his chest is what causes him the most dysphoria. Packing is just what it sounds like. It's wearing padding or a phallic object in the front of the pants or underwear to give the appearance of having a penis or bulge. I mostly mention this so you're not surprised by it if you happen to need to do a GU exam for one of your transmasculine patients. Some patients will pack for safety reasons. Other people may do it for aesthetics, but that might be there. And so it's just one of those things to know about, so you don't accidentally seem surprised and maybe lose a little bit of trust from your patients. So to conclude our case, we determined the patient is a candidate for gender-affirming hormonal care, and we counseled on expectations for therapy and the timeline. We decided to stop or recommended stopping the over-the-counter natural aromatase inhibitor. We don't have great evidence for that, and it might have been contributing to this emotional dysregulation. And we concurrently started blood pressure management with low-dose testosterone. We did testosterone cypionate 100 intramuscularly every 2 weeks with close blood pressure follow-up, and we'll plan to see them back in 3 months. Other primary care things to follow up: patient had a high BMI, probably would benefit from some risk stratification, diabetes, thyroid screening. We should follow up the depression and ADHD management and see how that contributes to, changes potentially in our care, and cancer screening. So for cancer screening, I encourage you to not get in your head about cancer screening for trans patients in general. You want to do an anatomic or an organ inventory of your patients, and you probably already got a really good detailed history to let you know if patients have had surgeries or anything like that that would affect this. So what organs they have are the screening that we'll potentially do. If a transmasculine patient has not had any surgical intervention, you can assume that they may have a vagina, ovaries, uterus and cervix, breasts, and a colon. And so generally, if there's no surgery, you're just using the guidelines that go with the organs that you have. There are some patients who have had chest reconstruction and may have other risks, and you might need to individualize that screening, perhaps using ultrasound or MRI if they have family history or other risk factors. Other cancer considerations: there's understandably a concern for testosterone exposure to the endometrium. The concept of aromatization and estrogen only affecting endometrial tissue that could cause hyperplasia and potentially a risk of cancer. But most evidence that we currently have suggests it ultimately over time leads to endometrial atrophy and can potentially actually reduce the risk of endometrial hyperplasia. But it doesn't mean we're not going to screen for symptoms like abnormal uterine bleeding after cessation of menses, which we expect to happen pretty early on in hormonal therapy. Bone health, people get a little bit caught up with bone health. Remember that estrogen and testosterone both support bone formation. So when you're thinking about bone health in these patients, you're really looking for absence of those hormones in whatever degree, whether that be after gonadectomy, if there's subtherapeutic hormonal levels. So decreased sex hormone levels are associated with a greater risk of osteoporosis. And in general, you're going to look at what that patient's hormone panel most mimics, and use the gender that is most aligned with the hormone panel your patient has. Certainly, you're going to look for the same risk factors for osteoporosis as you would in other patients. So some take-home points: gender affirming care is primary care. We need to know about the unique barriers to care that our patients face, and knowledge about them is going to make us more trustworthy partners in their care. We have the ability to change the narrative by being informed and identifying gaps and seeking education. You probably already know a lot, and there's a lot of good resources for you. With that, I'll take any questions.
Thank you, Dr. Thank you, Dr. Gonzalez, for reviewing that important topic. We have a moment for just a few questions. Let me begin by first asking you about the dosing of the testosterone. Oftentimes, transgender males have expectations, which I understand you have to set, that they really want their levels at a certain predetermined amount. And of course, that determines on when you measure the level relative to when they have the injection. So so it's not just a simple matter of titrating the dose to a certain level, and that's true of all hormones, right? But how do you advise how do you advise the general medicine practitioners that would be starting therapy as to how to monitor their testosterone?
Yeah, so I think in general, we want to look at testosterone levels as we usually do in peaks and troughs. And I think that takes a little bit of coordination and education to the patients. I think that both cis and trans men sometimes come in with this same sort of desire, right, to have a certain level. And we have to sort of reframe it in terms of the gradual changes that we expect to see that are specific to transmasculine patients, right? So in terms of reframing in terms of goals and saying, you know, have we really reached 5 years, which is where we see the maximum effect? It again goes back to just knowing what are the expected changes we want to see over time and making sure that the patients feel comfortable with that and not feeling the pressure to budge on doses based off of these numbers when the greater goal is the physiologic change and the outward appearance.
Great. And one additional question, since I don't see anybody else in the audience asking. With regard to the hematocrit, so you didn't mention that in your follow-up. At what point would you weigh the benefits and versus, you know, weekly or frequent phlebotomies versus the increased cardiovascular burden
Yeah.
relative to the treatment? I mean, at what point is do no harm greater than do harm?
Yeah, I think that's a great question because our patient did have increasing hemoglobin and hematocrit levels. We usually would use the same cutoffs that we would to say we should hold therapy if the hemoglobin's above 18, hematocrit above 54. That would be like a stop for now, and we have to do close follow-up to reassess. But some patients just don't know that this is a side effect and that therapeutic phlebotomy is an option to help them still be able to get their therapy. But certainly, if something is going to cause risk to our patients, it's a matter of counseling them, getting them into care for that sort of phlebotomy and close lab follow-up, and then feeling comfortable also resuming care. I think you also have to rule out that there's not a secondary cause, right? Which we all would naturally probably do.
So as a clinician, someone who has clearly an elevated hemoglobin that and has coronary artery disease and is at risk, an older individual, at what point do you say, I just can't do this anymore, even though the patient wants it? And it's a little bit of an unfair question, but I see this all the time.
Yeah, I think it's a hard question and a good opportunity for primary care doctors to pull in other specialists to weigh in on that, right? You don't need to make big decisions like this on your own for your patients, and they come up all the time. You really want to put it into the context that gender affirming care can be life-saving for some patients, right? And so you weigh that against the other sort of risk factors that may also threaten their life. And you do that in partnership with multiple specialists, the patient, and anybody else who could help.
Thank you, Dr. Gonzalez.
Our next speaker is Dr. Trent Wang. He is an assistant professor of clinical medicine with the Division of Transplantation and Cellular Therapy. Since joining Sylvester Comprehensive Cancer Center, his clinical focus has been treating patients with hematologic cancers who require allogenic hematopoietic stem cell transplantation and other cellular therapies. Dr. Wang's research focuses on complications of allogenic hematopoietic stem cell transplantation, including conducting interventional, behavioral, and retrospective studies of graft-versus-host disease, infectious transplant complications, and transplant survivorship. Dr. Wang also studies the outcomes of immune effector cell therapies such as CAR T cells for various oncologic indications. Please welcome Dr. Wang.
Thanks for the introduction. I'm going to be talking about the burden of chronic graft-versus-host disease and kind of the trajectory that the field has really taken in the last several years because we've made a ton of progress. My disclosures are listed here. I have done some advisory boards and received research funding from companies that work in the GVHD space. I'm a huge college football guy, so I'm going to kind of analogize this here. is 9-0. You know, this is going to continue. We're doing great. Complementary football is something that is important. It's in the NFL. It's kind of leveraging your team's strengths and building around it. And that's kind of what we've been trying to do here in GVHD as well. This little logo you see is going to kind of signify trials that we've taken part in and participated and contributed to throughout the slide. So A little bit of background information. So we do allogeneic stem cell transplantation in cases where we really need to. It's a high risk, high reward procedure. It relies on an immunotherapy effect, this graft versus tumor or leukemia effect to cure advanced blood cancers or bone marrow failure syndromes. The donor antigen presenting cells activate the T cells and eventually cause the beneficial graft versus leukemia effect, but we really have difficulty separating it from the graft versus host disease, which is the off-target tissue damage, rather. This graphic on the right is the classic one that we like to show. It's over 2,000 patients treated for stem cell transplant in the 1980s, really. Most of these patients were CML, which is a rare indication these days because of TKIs such as imatinib, but you can clearly see the relapse rate is inversely proportional to the degree of graft versus host disease, and that those who had a twin, which is a syngeneic transplant or a transplant with T cell depletion, had the highest rates of relapse, whereas those with a lot of GVHD had the lowest. This is a chronic GVHD lecture, but you always have to mention acute GVHD anyway, since this is sometimes a predictor of chronic, and it's something that happens earlier in the disease course. Acute GVHD happens in at least half of patients despite prophylaxis, and with treatment, which is corticosteroid based, there's still pretty poor outcomes. And those who don't respond to corticosteroids, non-relapse mortality at 18 months is 50%. That's an astronomical number, so it's really signifying this risk. The images here are just depictions of skin and colon involvement. Chronic GVHD develops months later after transplant, usually after 3 months. It's fairly prevalent. 40% of transplant survivors do develop this, and it can lead to irreversible target organ damage and quality of life impact. Studies in the second and later treatment lines demonstrate high rates of infection, not only because of the treatments that we use for it, which are immune suppressants, but also because having chronic GVHD represents a dysregulated immune system state. This graphic is really significant. It shows that even in these cancer-free survivors from allogeneic transplant, after 2 years of making it through all this stuff that we put them through, that dying from a non-relapse related death is approaching 40% at 12 years and doesn't even have a plateau. So these are still, even a decade out, a very high-risk population. And more images for chronic GVHD. This is a patient's inner arm, which shows sclerotic skin disease, superficial morphea, and some areas of erythema on the chest. The mouth can have areas of erythema or lichenoid changes, and it can affect the joints, causing fasciitis, joint restrictions, difficulty with ADLs, and much more. This is just a few representative images. So when we, as the transplant clinicians, see these patients from our time-to-time visits, we have a job to assess each of their organs. There's 8 major organs that we look at for patients with chronic GVHD, and we kind of grade the severity from 0 to 3 for each organ, 3 being the most advanced or serious. Here, for example, skin with a significant BSA involvement or sclerotic disease would be a 3, whereas a 1 is, a small amount of it. We grade each of these organs, and then we follow it from time to time. A reduction in the score, it would be a response. A increase would be a progressive disease, and then we kind of add all of those up to get an idea of how the patient is doing. So let's go back. So the prevention, defense, how do we kind of get less of the chronic GVHD problem? Well, HLA matching has traditionally been the best thing to predict outcomes. If you have a HLA match donor, which we consider 8 out of 8, it used to kind of predict the smoothest course, the best survival, and generally less GVHD that was severe. So the likelihood of identifying someone with an HLA match donor is actually strongly associated with luck, and racial ethnic background plays a huge part of that. It's not just that the donor registry, which has over 40 million participants, plays a part in representation, but also the genetic diversity of our ethnic background. This study was published 10 years ago, but shows that the likelihood of a white European finding an 8 out of 8 HLA match and getting to transplant was 75%, whereas for an African American or a Hispanic South or Central American, that percentage drops a lot from 19 to 30%, right? So now more and more studies are showing that we're tailoring the way we prevent GVHD based on what kind of match we have. Those who don't have an 8 out of 8 match undergo these higher risk alternative donor transplants, which use these mismatched unrelated donors. That's a 7 out of 8 or less. Cord transplantation, which is really losing steam in this day and age just because of the ease of the other types of transplants, and the haploidentical half matches from a family member. So classically, GVHD prophylaxis used calcineurin inhibitor-based regimens. That's tacrolimus, cyclosporin, and those did fine, but they had pretty high rates of chronic GVHD. The newer regimens include post-transplant cyclophosphamide, abatacept, and graft manipulation, which I'm going to talk a little bit more about in the subsequent slides. But this is post-transplant cyclophosphamide. It's called post-transplant because we give it after infusing stem cells. We give it on day 3 and 4. It's really cool. It's easy to do, and it's changed the outcomes and how we practice entirely. But essentially, the rationale is this dose of chemotherapy kind of rebalances the amount of T regulatory cells to T conventional cells, putting more permissive cells in there, relatively speaking, and it, for the most part, leaves the stem cells alone, so we can still get engraftment. And through this, it's been able to overcome many HLA barriers that led to severe GVHD or outright rejection early on. On the left is the original haploidentical studies that kind of proved post-transplant Cy was feasible. This is a 4 out of 8 transplant. No one imagined that this would work before this kind of platform. And then in the middle is with the mismatched transplants, 7 out of 8 or less, which I have a couple slides on later, but it also showed that graft-versus-host disease, chronic graft-versus-host disease was reasonable, manageable in the kind of 20 to 35% range. And recently, phase 3 study in reduced intensity matched transplant is showing that post-transplant cyclophosphamide reduces chronic GVHD rates. So we're starting to adopt it everywhere. And importantly, it's reducing the burden of chronic GVHD altogether. These are registry studies that are showing the number of affected organs is less, as well as kind of the distribution of what organs, especially mouth, seems to be reducing in frequency. Abatacept is actually mentioned here because it's FDA approved for prevention of acute GVHD. It's a CTLA-4 immunoglobulin that's given for about 4 doses around the stem cell infusion time. And it really is effective at reducing acute GVHD, but actually on chronic GVHD, it doesn't make any impact. In fact, on this study, it was 44% versus 36%, a little bit higher rates of chronic GVHD. Probably we don't know the right dosing regimen for this yet. So this story is yet to be completed. And then there's also ways that we can engineer the graft and kind of rebalance how many regulatory cells to conventional alloreactive cells there are, doing it manually rather than through the post-transplant cyclophosphamide. The ORCA-T platform, which we ran the study here as well, kind of does this and infuses the conventional cells 2 days later than the rest of the stem cells. And it's shown some very promising early signals of decreased rates of severe acute as well as chronic GVHD, and at least in a small study, extremely promising overall survival at 1 year. They just finished the phase 3 enrollment, and we're gonna hopefully hear about it within the coming months. So in Miami, obviously we have a lot of ethnic minority groups. We have a very challenging transplant population. About 40% of our transplant volume is considered alternative donor transplantation. This obviously is contributed by the patients that we are serving. Dr. Jimenez from our group has nationally led many of these efforts. This is the 15 MMUD study, which demonstrated the feasibility of using post-transplant cyclophosphamide in 7 out of 8 donors, which you have a much broader pool of availability than a matched 8 out of 8 donor. In these 80 patients, we contributed 18 patients from our group, and it showed very promising survival, as well as, like I mentioned earlier, the chronic GVHD rates were parallel to what we would expect in a matched transplant, really. And then subsequently, this paper is a registry paper of over 10,000 people looking at PT-Cy outcomes in matched as well as mismatched transplants. the summary here is that PT-Psi really is the important factor, and it really reduces its disparity in outcomes, depending on, doesn't even matter as much who the donors are. This is a huge game changer for getting patients to transplants when they need it. Currently, we just completed enrollment of the NMDP Access study, which is similar to the 15 MMUD study of mismatched transplantation. We're using peripheral blood in this study instead of bone marrow. And we are actively enrolling in what's called the Optimize Access study. Again, in 7 out of 8 donors or less, we're using lower doses of post-transplant Psi to see if we can get similar engraftment, reduce graft-versus-host disease kinetics, but really the primary outcome is to see if we can reduce infection and morbidity from the high dose of chemotherapy there. All right, moving on to offense. Once you already have the problem, you have to treat the problem. GVHD treatment is something of a marathon. Once patients develop chronic GVHD, it's not something that will go away in weeks or months. It's on the order of years, even decades. And it comes in a pattern that involves flares and improvements in flares. But over time, especially over the order of many, many years, you will see clinical tolerance and general reduction in the amount of needed immune suppression. So our goal as a transplant clinician is to balance all of this treatment, because we know if we keep them in adequate shape long enough, we should get somewhere good. However, if we give them too little treatment, we're going to see irreversible organ damage and quality of life issues. If we give them too much treatment, you've seen from the other survival graphs, there's infections and drug-related toxicities. This is a graphic I made. Very proud of it. The advent of transplant in 1957 showed a lot of nothing happening for the treatment of GVHD. But suddenly in 2017, there was this rapid interest from pharmaceutical industry really about our patients, and they were focusing on how to reduce the GVHD symptoms and obtain responses. Since 2017, we've had 4 FDA approvals, including 1 this year, very recently. And many of these new agents target the purported mechanisms that we think is causing the chronic GVHD, including different immune cells ranging from the monocytes and macrophages of B and the Ts, and different inflammatory pathways that are implicated. However, our first and every line of treatment for chronic GVHD is still steroids. It's prednisone. It's 1 milligram per kilogram. Sometimes the older data suggests you might add on sirolimus or calcineurin inhibitor with it, but it's still prednisone, and the response rates are still only about 60%. And once you taper, you tend to see the possibility of worsening again. So you can't stay on prednisone forever. Everyone in this room knows that. It's associated with so many side effects, the neuropsychiatric ones, infections, musculoskeletal, you name it, it's going to happen. So what do we do? Well, let's add things to it and see if it improves, right? First line studies have actually been in abundance in the last few years. We've always been trying to reduce the worsening of these chronic GVHD patients early on. Large phase 3 studies or large phase 2 studies have been done, but they've all been negative. Nothing has worked so far. This is from the NIH Consensus Development Project for how to proceed, kind of the roadmap for chronic GVHD in the coming years. But the one I wanted to highlight is for initial systemic therapy, we need to get away from steroids. It's a little bit controversial because we know how important they are, but this is, expert consensus. We need to try. So right now, one of the pharmaceutical studies is looking at this strategy of 2 arms without steroids and 1 arm with steroids and randomizing it. And we currently have this through our study startup. We hope to be able to start accruing on this study by the early 2025. And the reason we do all this for the first line to try to reduce the incidence of the second line is because second line treatment really is bad. This is actually from a phase 3 trial, best available therapy. So this is a comparator arm of ruxolitinib, actually. And you can see that the response rates in the second or later lines for chronic GVHD are in the 20 to 30% range. That's terrible. And this is what the best we had for the longest time. So there's clearly an area of need. The first drug approved for chronic GVHD was ibrutinib, which we used initially for CLL. It's a BTK ITK inhibitor. It was approved by the FDA on the basis of a 50-patient study, which was actually kind of unbelievable. And this study targeted, I would say it cherry-picked a subset of patients who are actually extremely responsive to immune suppression, especially steroids, those with erythematous red rash or oral erythema. Those guys tend to respond to anything you put on them. But, you know, lo and behold, on this study, they had over 60% response rates, which was great. So it's been approved. The transplant community doesn't really believe in this drug as expected. It's also fairly toxic as things go. Remember, these are drugs that you're going to have to stay on for months and months and months, maybe longer. So the rates of infection are fairly high, and the cardiovascular side effects really make this difficult to implement. Belumosudil, a trial that we participated in, is a ROCK2 inhibitor, which targets inflammation as well as specifically the profibrotic pathways. This drug did show some very promising activity with response rates in the 70% range across all organs. It also seems to be very, very, very well tolerated, doesn't cause much in terms of side effects at all. So FDA approved, totally practice changing. Everyone's on this drug now. And ruxolitinib, the one that I showed you the best comparator arm to, is actually something that was already approved for treatment of acute graft-versus-host disease. They looked at it in chronic. Lo and behold, in this phase 3 randomized open label trial, it also had very good activity. This response rate is actually at 6 months, not by 6 months. So the by 6 months was also comparable in the 60 to 70% range, and it showed very good failure-free survival for, you know, lack of progression on the drug. Also something we use extremely commonly. The newest player on the block is axatilimab, which is a CSF1R antibody, which blocks the monocyte to macrophage pathways. This is IV, different than the last few we talked about, which are all pills. We were able to be a part of this study as well in the dose finding section of it. They found that 0.3 milligrams did really well, had response rates that were also, you know, in the 60-70% range. But this population included many of the people who had already received novel agents such as belumosudil or ruxolitinib. So again, they looked at a larger population of 240 patients. This was just published in the NEJM this year, and it showed 74% response rate at the lowest dose group, whereas at the 3 milligram dose group, the response rate was only 50%. No one knew what the heck was going on here, and it's still a little bit of a mystery, but obviously development is continuing at the lowest dose group, which incidentally is the safest. I'll get back to that in a moment, but I'm going to make a pitch for extracorporeal photopheresis. This is an apheresis-based treatment where we take out the blood, the buffy coat, we add methoxysorlin and UVA light. It probably works as a dendritic cell therapy, although we're not exactly sure how the mechanism is. It's definitely anti-inflammatory, and we definitely see responses to it. However, the best part of this is it doesn't seem to confer added infectious risk. So for high-risk patients that we have, for those with advanced sclerotic disease, we tend to use it all the time. It's well tolerated other than the fact that it's a huge time commitment. It's 2 to 3 hours twice a week for at least 3 months, and then you taper that schedule. This is Michael and Mom. That's literally how they go by. They're patients of ours, and they have a fairly large social media presence for not only lymphoma, but GVHD. And here's an image of him getting ECP. He's been on it for over 2 years at this point, and he's definitely extracted benefit from it. Check out his webpage if you can. They talk a lot about survivorship issues. And so I bring that up because ECP, while not FDA approved, is CMS approved. We have access to it for treatment of chronic GVHD, and while it's well tolerated, axatilimab is something that's well tolerated and is also parenteral. So we thought, why don't we try to combine these two agents and see if perhaps we get any added response, especially in this very high-risk population. We don't use ECP on the run-of-the-mill chronic GVHD patient. So we pitched this idea to one of our pharmaceutical partners of a combination trial for 6 months of both of these agents. And just given the nature of chronic GVHD trials, it'd be multi-center. We have 5 sites selected for it. They approved this study. This is going through the final phases of IRB and contracting. Also hope to get this study up and running by early 2025. And finally, we're going to talk a little bit about special teams and areas of focus that we may not think about every day. This is Dr. Lara Traeger from our behavioral medicine group. There's huge needs for chronic GVHD patients that I haven't yet spoken about. Despite the treatment, this disease causes huge quality of life impact. It impacts their ability to work, their daily routines, their social roles. And importantly, it causes a huge feeling of isolation among patients who are frequently seeking out groups online or people who, can empathize with them because it's such a rare disease. And as a result of all of this, there's high rates of depression, anxiety, other psychological stress measures. So Dr. Traeger, who comes to us from Mass General and has been at Sylvester for, I think, a little less than 2 years, brought a lot of her expertise in this domain to us, fortunately. And she's been developing this multidisciplinary group-based intervention for survivors with chronic GVHD. And these group sessions have at least 5 patients. They generally include a BMT clinician and a behavioral health specialist. It's done through teleconference. We've been using Zoom for these. There's this 8 sessions of 90 minutes each where we cover clinical as well as behavioral topics relating to GVHD survivorship. Sometimes it's about symptoms, sometimes it's about relationships, health intimacy, and coping strategies. This was initially run as a pilot in Mass General, which got very good feedback. And then we are implementing it at Sylvester in a different way. Not all Mass General studies can be broadly applicable, right? So it is being very well received by our patients as well. And we also have Spanish speaking only groups, which are new to this study. Here's the title page of a workbook that the patients get. We're almost done with the 2 Spanish speaking groups. And then, of course, how do you get this to a broader patient population? Well, we think about digital health applications because in rare diseases, supportive care clinicians are limited. Not everyone has access to them. These will increase our capacity to provide these supportive care options to patients. This is some screenshots of the Horizons application where we took that curriculum and put it in the form of an app. A couple of more screenshots. As you can see, the patients have this little pathway they can navigate. There's several games built in. There's little sections that they can click on to learn more about each organ that may be involved, including some strategies in terms of what to look for, how to deal with it. And then there's also patient videos about how the patients share their experiences with them. So for the Horizons program, this pilot app is being run through IRB right now. There's also an R01 study that's multi-site between us, Mass General, and BMT InfoNet that's going to start in the next, probably next year, next 6 months. We're also running a similar app for sexual health survivorship. I'm dealing with symptoms after transplant. This is a digital health app that will be offered to patients within our clinics as well. And then this will take 1 more minute, but this is a digital health app that we've been designing from the ground up. It's for patients who are on corticosteroids. These are very toxic drugs with complex adherence because of the dosing regimens and the tapering and then the re-escalations. So we thought, what if we put this all together, made an app designed to help them taper the drug, help them learn about what to look for, what other medications are important, as well as how to manage these symptoms that are not only physical, but can be neuropsychiatric. We've gotten Sylvester support funding to develop this app, as well as a little bit of pharmaceutical support. And so far, it's been a huge learning experience. I don't know if anyone's developed an app before, but it's not easy, and it costs in the hundreds of thousands of dollars. But we have made a lot of progress there. So one of our medical students, Yitzhar Goretsky, has been helping us with this app a lot too. And that's it. Here are my acknowledgements. Thank you so much.
Thank you, Dr. Wang, for that interesting and important grand rounds and for dedicating your life to a disease that is very devastating and for which there is no cure. I'm surprised that GLP-1 agonists have not yet been thrown into this mix, seeing how they treat everything else. But That wasn't my question. My question is whether or not you can learn, is there anything to be learned from those patients who get GVD, but then recover and don't get it again? Is there something that you have identified in those patients who sort of beat the system and that you can harness to prevent a recurrence or chronic?
Yeah, I think that's a difficult question to answer. The short answer is not exactly, but we are working on several biomarker-based studies that help us predict the likelihood of developing severe GVHD early on, including on day 14 or 17 after transplant. We draw several biomarkers from the blood, and then the level of this biomarker is actually associated with, the likelihood of a non-relapse mortality event, as well as GVHD developing in the acute sense. There's also biomarkers predicting who will develop chronic GVHD. They're not as validated as the acute ones, but they're definitely in development right now.
Excellent. Well, I thank both our speakers today for great grand rounds. I remind everyone to look on the chat for the link for the CME and MOC credit link, and look forward to seeing you all next week. Have a great week. And those of you that are online, it's really better in person. So perhaps you'll join us next time.